Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 487 of our pharmacotherapy series, which majors in ischemic and hemorrhagic stroke. We will continue discussing the case of patient PCP in parts 485 and 486 of this pharmacotherapy series. My next question to you reads: what other non-pharmacological interventions might be also considered for the acute treatment of stroke in PCP? A number of endovascular treatment options for ischemic stroke are available and include intra-arterial fibrinolytics, mechanical thrombectomy with coil retrievers such as the mechanical clot retrieval system, MERC, or stent retrievers such as Solitaire FR and Trevo, combination intra-arterial thrombolytics with mechanical thrombectomy, mechanical clot aspiration with the penumbra system, and acute angioplasty and stenting. Intra-arterial thrombolytics administration requires an experienced stroke center and careful selection to identify patients who would benefit. As with intravenous fibrinolytics, intra-arterial thrombolytics should be administered within 6 hours of onset of symptoms, in patients with occlusions of the middle cerebral artery who are not candidates for intravenous all-TEPLES. Urokinase is the only fibrinolytic with randomized trials that has been shown to be effective in clot lysis, resulting in recanalization and restoration of blood flow. While intra-arterial thrombolytics can be considered when intravenous fibrinolytics is predicted to fail, large vessel occlusion, or is contraindicated, these therapies, if available to be administered by a skillful interventional neuroradiologist, should be considered. Lack of identification of optimal dose and evidence of effectiveness in occlusions outside of the middle cerebral artery limit the widespread use of intra-arterial thrombolytics. Mechanical removal of the clot has been evaluated alone or in combination with pharmacological fibrinolysis. 4 devices are currently available, namely MERC, Penumbra, Solitaire FR, and Trevo. The most current guidelines recommend using the stent retrievers, that is Solitaire or Trevo, over coil retrievers, such as MERC. The most recent evidence with these devices is promising. In patients with stroke secondary to occlusions in the proximal anterior intracranial circulation, patients who underwent thrombectomy using a stent retriever device, Solitaire, after receiving intravenous all-TEPLES reduced significantly the 90 days disability without increasing risk of intracerebral hemorrhage or mortality compared to intravenous all-TEPLES monotherapy. Similar results were also found in 4 other trials comparing endovascular therapy with intravenous thrombolytics to standard therapy with intravenous thrombolytics alone for documented large occlusions in the proximal anterior circulation. Intraarterial thrombectomy reduced disability and improved outcomes. These trials compared to earlier trials required angiographic confirmation by CT of an intracranial occlusion for eligibility, while earlier trials that did not require such confirmation or used older devices, that is Mercy and Penumbra, did not find such benefit. The next question reads, what information and instruction should be given to PCP regarding future stroke symptoms? Early treatment of acute stroke with available or investigational drugs appears to be the most important factor in determining optimal outcome. Nearly every clinical trial demonstrating some benefit of pharmacotherapy for acute stroke has shown the greatest effect for patients who are treated within a few hours of the onset of stroke symptoms. Immediate detection of stroke symptoms and initiation of treatment are imperative. The primary rate-limiting step in diagnosis and provision of medical care is recognition by the patient of stroke symptoms. Every patient who is at increased risk of stroke should be carefully instructed to seek emergent medical attention if they experience any weakness or paralysis, speech impairment, numbness, blurred vision or sudden loss of vision, or altered level of consciousness. These symptoms should be handled with the same urgency as the symptoms of a myocardial infarction. The pharmacist should ensure that PCP and his caregivers know the symptoms of stroke and understand what to do if they occur. The next question reads, what complications associated with stroke might PCP experience? Agitation, delirium, stupor, coma, cerebral edema, and increased intracranial pressure are other acute symptoms that can be associated with ischemic stroke. These symptoms correlate with the specific blood vessels that are affected, and the development of these complications in PCP would depend on the progression of his stroke. Seizures may occur in up to 20% of stroke patients. Pneumonia, pulmonary edema, cardiac arrest, deep vein thrombosis, and arrhythmias are commonly associated with ischemic stroke and should be managed as they occur. In PCP, these may occur soon after his stroke or be related to a rapidly developing neurologic event such as further infarction, hemorrhage, or severe cerebral edema. Pneumonia or deep venous thromboses are related primarily to inactivity, and the risk of these events will increase the longer PCP remains immobile. Stroke patients frequently experience psychologic reactions. The most common psychiatric complication is depression, occurring in 30% to 50% of patients. The severity of depression varies from mild to major depressive episodes. If the depression interferes with recovery and the rehabilitative process, it should be managed with the use of a selective serotonin reuptake inhibitor or other appropriate agent. Severe psychomotor depression may respond to CNS stimulants, such as methylphenidate or dextroamphetamine. Because of PCP's hypertension, stimulants should be used only with careful blood pressure monitoring. After 4 days in the hospital, PCP's neurologic status is stabilized. So my next question to you is, will further neurologic improvements be realized? Neurologic deficits in stroke patients are not considered stable or fixed until at least 8 to 12 months have elapsed. During this time, neurologic function may return but rarely to normal. The prognosis after ischemic stroke depends on a variety of factors including age, hypertension, coma, cardiopulmonary complications, hypoxia, and neurogenic hyperventilation. However, infarction of the middle cerebral artery is associated with a poor chance for recovery. Recently, physical and occupational therapy techniques involving restriction of activity in the unaffected limb or limbs have proven to be effective in patients regaining lost function. Therefore, it is possible that PCP will experience further neurologic improvement. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 488.